Welcome to Truth Noodle Media, the YouTube-based arm of the educational website, The Truth Noodle. This video will cover the 11 views described in the 2013 Guidelines for Basic Perioperative Transesophageal Echocardiography, as published by the American Society of Echocardiography in conjunction with the Society of Cardiovascular Anesthesiologists. This will not include a number of additional views considered to be part of a comprehensive TEE evaluation. However, it is a good starting place for basic diagnostic and hemodynamic purposes in the ICU or non-cardiac operating rooms. The mid-esophageal 4-chamber view is often the first obtained after introducing the probe, and I recommend using it as a reference and a home base of sorts whenever you feel like your sense of orientation has become lost. To obtain it, set the omniplane to 0 degrees and simply advance the probe until it is behind the left atrium. Adjust the depth of the ultrasound image as necessary to image the entire heart and pericardium. From the mid-esophageal location, the left atrium will always sit closest to the transducer and will be at the top of the 2D display. Other structures seen are the mitral valve, left ventricle, the right atrium, tricuspid valve, and the right ventricle. Gentle retroflexion of the probe tip is often required to avoid foreshortening the left ventricle. Despite the clear pictures of a 4-chamber view you will often see shown and that are visible on this simulator, it is often difficult to view all 4 chambers in one image. In this case, it may be preferred to make 2 separate images, an LV focus view with the probe rotated left, focusing on the left atrium and left ventricle, and an RV focus view with the probe rotated to the right, focusing on the right atrium and right ventricle. For this view, the omniplane is typically set to 0 degrees, though occasionally a 5-chamber view is seen at this angle. In this case, either advance the probe slightly to move it below the level of the aortic valve, or slowly increase the omniplane up to 15 or 20 degrees until the aortic valve disappears. To obtain the mid-esophageal 2-chamber view, begin with a mid-esophageal 4-chamber, center the mitral valve and left ventricle on the display, and then increase the omniplane up to 90 degrees. This change in omniplane means that the right side of the image display is now superior and the left side is now inferior. The left atrial appendage is often seen on the right side of the display as it is an anterior structure along with the anterior wall of the left ventricle. The inferior wall of the LV is imaged on the left side of the display. From the same probe location as the mid-esophageal 4 and 2-chamber views, increase the omniplane up to somewhere in the range of 120 to 140 degrees to obtain the mid-esophageal long axis view. This view is optimized when the LV cavity is made to look as large as possible, with the full left ventricular outflow tract and aortic root visible. Structures imaged here include the left atrium, mitral valve with its anterior and posterior leaflets, the left ventricle, the LVOT, the aortic valve, and a small portion of the right ventricular outflow tract. The easiest way to obtain the upper esophageal ascending aortic long axis view is to begin with the mid-esophageal long axis and focus on the aortic root. While continuing to focus on the aortic root, gently withdraw the probe to image the ascending aorta. The arch itself is difficult to image with TEE due to dropout from the trachea and the right mainstem bronchus, so the image quality will degrade as the probe moves more superiorly, but the ascending portion of the aorta should be able to be visualized. The right pulmonary artery will be seen in cross-section between the transducer and the ascending aorta in this location. This view can be obtained beginning with the upper esophageal ascending aortic long axis view and simply decreasing the omniplane to between 0 and 30 degrees. However, as a learner, I found it easier to obtain beginning from the mid-esophageal 4-chamber view. From this location, simply begin withdrawing the probe, centering on the aortic valve, until the probe moves superior to the level of the aortic valve. This will show the ascending aorta in short axis, and gentle retroflexion should bring the main and right pulmonary arteries into focus. The SVC is the third vessel seen underneath the right pulmonary artery and next to the ascending aorta. The mid-esophageal ascending aortic valve short-axis view can be obtained from the mid-esophageal four-chamber view by increasing the omniplane to around 30 degrees and slowly withdrawing the probe until all three leaflets of the aortic valve are visualized. Structures seen here include the left atrium, the right atrium, the interatrial septum, a portion of the right ventricular outflow tract, and the aortic valve itself. The leaflets are named by their association with the coronary arteries. The right coronary artery comes off the right coronary cusp, which is seen at the bottom of the image, next to the right ventricle. The left coronary artery comes off the left cusp, seen on the right side of the screen. The remaining cusp has no affiliated artery and is called the non-coronary cusp, or the non. This is seen next to the interatrial septum. When learning, I found it easiest to first identify the non-coronary cusp, which will always be next to the interatrial septum, then the right cusp as it is next to the right ventricle, leaving the remaining cusp as the left coronary cusp. This view is best seen around 60 degrees of omniplane from the mid-esophageal location. Make fine adjustments to the depth of the probe and the angle of the omniplane to optimize the tricuspid valve, the RVOT, and the pulmonic valve in the image. This view is helpful for interrogating the tricuspid and pulmonic valves, gauging movement of the RV free wall, and can also help to float a PA catheter or query its position once it's in place. The mid-esophageal bicaval view is found with the omniplane at 90 degrees and the probe rotated to the right until the SVC and IVC are opened up. At 90 degrees omniplane, the superior SVC is seen on the right side of the display, with the inferior IVC on the left side. This view is helpful when confirming wire location during placement of a central line. If placed correctly, the J-tip of the wire should be clearly visible coming down the SVC as the proceduralist advances the wire. The other structure commonly interrogated from this view is the fossa ovalis, seen best by rotating the probe slightly from right to left until the thinnest part of the interatrial septum is seen. This would be the location of a PFO if present. This is the only transgastric view recommended as part of the 11 basic views, however, it can provide quite a bit of information. It is best obtained by starting with the mid-esophageal four-chamber view and advancing the probe deeper into the stomach. Often, the view will degrade when the probe passes into the stomach due to poor contact with the stomach wall. Recall that air is a poor conductor of ultrasound. This can be solved by antiflexing the probe until contact is made with the stomach wall and the image clears up. This image is considered optimized when both papillary muscles are viewed in cross-section and the ventricle is made to look as round as possible. The segment of myocardium closest to the probe and at the top of the screen is the inferior wall of the left ventricle. The anterior wall is opposite towards the bottom of the screen. This view is particularly high yield for the purposes of ICU or rescue echo, since it can be used to make rapid assessments of global as well as regional left ventricular function. It is the only view that images all three major coronary distributions in the same image. These last two views image only the descending thoracic aorta, which sits directly behind the esophagus. It can be found by rotating the probe roughly 180 degrees so that the ultrasound beam projects posterior to the heart. With the omniplane at 0 degrees, the descending thoracic aorta will be imaged in cross-section. This can be used to diagnose aortic dissections, however for our purposes, it is probably more commonly used to identify wire and device placement during procedures such as peripheral VA ECMO cannulation or placement of an intra-aortic balloon pump. By withdrawing and advancing the probe with the aorta in view, the entire descending thoracic aorta can be imaged. This final view is found at the same location as the descending thoracic aortic short axis view, but with the omniplane increased to 90 degrees to image the descending thoracic aorta in long axis. Again, with the omniplane at 90, the right side of the display is superior and the left side is inferior.